Now DAPT, okay, dual antiplatelet therapy. And you're gonna see there's a lot of discussion on this now because we're trying to figure out, after these patients had the stent, they've gotten the anticoagulation, is what do we do next? Do we continue it forever? And what's the reason why we want to continue it forever is we have a risk of bleeding. And that bleeding can be significant, where these patients get hospitalized. And they can be hospitalized, they can even die. So we want to make sure, remember, first do no harm. When we're talking about everything we're doing in these lectures is we don't want to cause harm. So when do we continue them and for how long? So remember we talked about dual platelet antitherapy. So when a cardiologist says, I want DAPT, okay, they're gonna give you this. I want DAPT, and this is gonna be aspirin with the P2Y receptor blocker. And we've talked about those. So your main ones are gonna be clopidogrel, prasugrel, or ticagrelor. Now, there's different types of stents. And we talked about when that stent gets opened up, there's called a bare metal stent. And this is it's basically like a steel cage that goes in there, and well, it's titanium. It goes in there, opens up, and keeps that vessel. Why do you use this? Why would you use these? Is patients who, first of all, maybe you can't trust them to take medications for an extended period of time. Maybe they don't have the resources, maybe they are unhoused, or they're homeless, or they have frequent GI bleeds, or maybe they have a risk of intracranial hemorrhage. They may have had multiple falls and had intracranial hemorrhages in the past. You want to avoid having anticoagulation for long periods of time, that dual platelet anticoagulation. Now, following an ACS event, that's acute coronary syndrome, stent or not, we want to continue with this for 12 months. And the discussion on the literature is there may be shortening on this. And there's a lot of research on this, and you'll see a lot of changes on this. Following a stent placed in a non-ACS setting, 6 months. Now, when would that be? Someone comes in for chest pain, and they're opening up the area, but they haven't had a heart attack. Does that make sense? We haven't had a heart attack, but we're trying to stop this angina that they're having is so bad that they can't carry on their daily functions of life. So you're trying to open this up. Remember, we're opening those roadways up so that it gets blood flow into the heart, because the heart is going to give a response of pain, and we're trying to stop this pain. We're opening those roadways so they get blood flow to those areas of the heart. Now, shorter duration may be possible due to improvements in the stent design. So remember, these stents are so sophisticated, and sometimes they're getting better and better, where they don't have to require as long as anticoagulation did in the past. And there's called the STOP trial. And in that trial is they did a dual anticoagulation for 1 month. Now, when would you need longer duration? Is when somebody has a complex coronary disease. And what I mean by complex is that when they looked at that tree, when we shot the dye into the heart, we looked at that tree in the angiogram. That tree shows lots of disease in different areas. Not just one area that got stented, multiple areas of disease. There can be also what's called a bifurcation stent, where stents are meeting each other, and whenever you have those stents meeting each other, there's increased risk of clotting. Left main stents, because this is a very important artery they need to keep open. This is where we'd want to have longer duration. And the patient has multiple stents placed through. If they have had recurring MIs, maybe they also have other disease. They have peripheral artery disease. Now, if there's a question, if you're working with a cardiology group and they're going to say, which P2Y inhibitor? Right now, it's ticagrelor is probably going to be their choice, is in considering. Prasugrel is less commonly used due to the limited supporting data. And when we go to monotherapy, we'll kind of discuss what is going to be the better monotherapy. Do we continue the aspirin or the P2Y inhibitor? So we go from, remember, we're going from dual platelet antitherapy to monotherapy. What do we want to continue? Now, it used to be in the past is we would continue aspirin. But more and more is it looks like clopidogrel, if you're going to use it, is going to be better and safer. And why is that? So overall, it reduced, remember, MACE is, whenever we're talking cardiology, we always want to use the term MACE. It reduced the major acute coronary events. Okay, these are the deaths that it reduced. So it stopped these deaths by continuing the clopidogrel versus the aspirin. And then the reason why in the past is that we thought we'd want to continue aspirin is we thought it would have less chance for bleed. Remember those GI bleed, those significant bleeds. But it really is, it's come down when the data has come out is actually clopidogrel and aspirin, the bleeding was actually a little bit less in the clopidogrel than it was in the aspirin. So that clopidogrel was clopidogrel itself was better and safer. Now, when it looks like the overall deaths in these patients, or morbidity and mortality, is about the same, but those are other factors that need to be worked through in further data. But in what it looks like now in the data is that to continue the clopidogrel. And then rarely used, as we discussed, this would be special cases, and when you're really doing triple anticoagulation is when you're doing aspirin plus the P2Y plus the oral anticoagulation. Now, you're going to see this has been, there's a lot of articles on this, there's a lot of discussions, lots of podcasts on this, is aspirin for primary prevention. Now, a lot of people I know that say, I take aspirin because it's good for me. Now, is aspirin really good for you? Well, it can be, but there's a big side effect of GI bleeds. And these GI bleeds can be significant, where someone could have to be put in the hospital or they can actually die from it. Now remember, primary prevention, we discussed and we'll keep in this, is an intervention at preventing the disease, at preventing primary prevention. Secondary, the disease has already occurred and you're avoiding further damage with this disease. Remember, aspirin inhibits the platelets and it stops aggregation. So what's the risk? The GI bleed, intracranial bleed, and hemorrhagic CVA. Okay, so these are things that we have to worry about. Is that you can have a significant bleed where this patient can have harm. Now, this is the current evidence, and this is probably going to be changed. I really feel that there is going to be only aspirin for primary prevention in very limited cases, because the more data is coming out where people are having harm. And it's hard for people to understand that because they see aspirins advertised on TV. It's really easy to purchase. You can go to your local drugstore and it's literally aisles of it, all different types. And their grandfather took aspirin, and this is something that they've thought to take. And I think I've had students that say, I take aspirin because I think it's good for me. So in ages 40 to 59, if they have a coronary vascular disease and its risk greater than 10, the conversation should be the risk-benefit of daily aspirin. So meaning sitting down with the provider and saying, hey, you have a high risk because we have suspected coronary disease. We need to see if this is going to be a good product for you to take. Less than 10%, aspirin is not recommended. Now, in the future, I bet you this is going to go away where there's not even going to be the conversation where it's not recommended to take aspirin in this age group. Greater than age 60, no aspirin should be given as a primary prevention, meaning before the disease, because the greater risk of GI bleeds and intracranial hemorrhages. All right, let's talk about acute coronary syndrome. Now, the duration of dual platelet aspirin therapy with aspirin clopidogrel after coronary artery syndrome. Minimum of 1 year, okay? This is without a stent place, okay? Or and then if a bare metal or drug-eluting, when you see that DES, it's a drug-eluting stent, or CABG. So except for personalized approach, so you want to consider doing a year, okay? Except if there's a personalized approach, this patient has increased risk of bleeding. Aspirin is to be continued indefinitely. Now, this is being questioned, and we're seeing more research where that aspirin is a good thing, but these bleeds can be significant and cause problems. Stopping aspirin for 1 to 2 months after PCI reduces bleeding without increasing MACE versus continued DAP. So continuing possibly clopidogrel, but stopping the aspirin itself. All right, now let's talk about fractional flow reserve. So fractional flow reserve, and this is done during a cardiac cath, and there's actually now in some of the CT scans where this can be done. And what this does is it's a technique of identifying functionally significant lesions within the coronary cath and coronary artery CT scans. So remember we talked about we're lighting up and we're looking at the vessels in the heart. And what the fractional flow reserve does is it helps us identify areas where we should put stents in. The ratio, and it gives the ratio of maximal myocardial blood flow through a narrow area to maximize the myocardial blood flow if that artery was normal. So basically it calculates what areas, and it gives a reason to place a stent. The fractional flow value below a threshold of 0.575 corresponds with an inducible ischemia, meaning this area needs to get a stent placed. And you're going, why do I need to learn this? Is because you're going to see these in these cath reports, and it gives them where they should put the stents and where the locations to place the stents. It reduces, remember we talked about this, so important, the MACE by 28%, reduces risk of death by 34%. And this is a big thing too, is it reduces the amount of stents placed, because what it's doing is it's telling them where to place them and if a stent should be placed. Now, what's the limitations with it? Adding a hyperemic agent. So these are agents that they have to get the calculation. They help open up the blood vessels. It increases blood flow to different tissues in the body. And it can change as challenging in diffuse disease and tandem lesions, meaning where there's lesions next to each other. And these agents can cause bronchospasms and hemodynamic instability. This is another measurement that's been done, and you can see these in the cath reports, is the instantaneous flow rate, the IFR. Another measurement that can be used for risk stratification. It's an instant wave-free ratio across the stenosis during the wave-free period where resistance is naturally consistent and minimized in cardiac cycle. So less than 0.89, you don't need to know this number, but it's just getting this information, is that a stent will be placed, and then you want to see improvement after the stent is placed. This is another test that's being done when we're doing a cardiac cath, is an intravascular ultrasonography, IVUS. And it shows the plaque vulnerability. Now, we briefly discussed it. We'll get a picture of this, what we're talking about, is it shows invasive imaging procedure that, so they basically go, while they're doing a cath, they stick a small ultrasound there, and it produces imaging of intravascular images of the coronary arteries. It gives it's a miniature ultrasound mounted catheter. It's a critical role in coronary atherosclerosis pathology. So we're looking at the arterial wall thickness, and we're looking at atheroma detection, calcium content, and dissection. And it's an aneurysm assessment, and it can show in-stent restenosis. So basically, you're looking at another view. So when you're going in there, first you're doing a cardiac cath, is you're lighting this up and you're seeing the vessels. Then you're sticking in this small ultrasound, and it gives you more data. It shows the type of plaques, soft, mixed, or calcified. We'll talk about why this is important. It gives venerable atherosclerotic lesions where there's a lipid rich within a thin fibrous cap. Now, the thin fibrous erythromas, these are thin borders, are large lipid cores, and are more likely to rupture. Here we go, is we're going to look at an example of this. So this kind of helps understand what we're looking at, is that, so this is where there's a thin fibrous cap that you can see right here. Change the color up on that. We have a thin fibrous cap. So normally, if you're just doing without the ultrasound, is this area, this lumen would light up on the coronary cath. And if we didn't stick the ultrasound there, we wouldn't notice that there's a thin fibrous cap. Because remember, it's just showing the inside, the lumens, the inside of the lumen. But what we're doing is we're looking for areas that are not showing that there's a stenosis, but there's a risk for rupture. So there's a risk of rupture in these, is that because the fibrous cap is thin in this lipid layer. And so what can happen is you can go through and someone can say, oh, the cardiac cath was clean, but then they go get a heart attack. And this is used to what happened is that this would rupture later. So now we're getting better technology so that we can take care of patients and look for these vulnerable lesions during a cardiac cath. Now, we talked about PCI. Now, why don't we just cath everybody? Just everybody who comes in who has chest pain, we just have the cath lab set up and they just run through the cath lab. Well, they're not perfect, because the fact is what can happen, there is chances, now it's very low and they're getting better and better, there is a chance of mortality from going through just having the procedure of the cath. There's periprocedural myocardial risk. There's a risk while you're doing this that someone can have a heart attack. You're going and you're sticking something inside somebody's heart. There's stent thrombosis. The stents can thrombose, and acute, less than 24 hours, and then 1 to 30 days, and it can happen 30 days to 1 year. It's mainly nowadays is from not taking the medications. Very late, greater than 1 year, is more frequent with a drug-eluting stent. And this is more than likely as they're not taking their medications. Stent thrombosis can cause an MI in 30 to 70% and death in 10 to 20%. You can also have restenosis, so you open that lesion up and then it stenoses again. And this can happen at 20 to 50% with a balloon angioplasty. That's where they go and open it up. It can happen to 10 to 30% with a bare metal stent. Now it's less than the drug-eluting stents. Where you'd have, so in the restenosis, remember those arteries are getting small again, those coronaries, you're gonna have worsening angina, you're gonna have risk for non-ST elevation, you can have ST elevation MI. The treatment would be a repeat PCI. Now you can also, the other complications of the PCIs, you can have bleeding, you can have at the vascular site. Now that's why they like doing the radial, is you are able to see it better and able to get better control of the bleed. But you can also have hematomas at the site, but you can also retroperitoneal bleed when you're doing the femoral site. That's where someone can go through the artery and into the vein, or the artery itself gets pierced when they're going through, and they can have a retroperitoneal bleed. You may not notice it right away. The patient may complain of back pain, which you may not notice, may think that they have chronic back pain, or if they're laying in one of the beds in the hospital, they're saying they have back pain. Sometimes some people don't have symptoms, and it can be as severe as these retroperitoneal bleeds. Also, too, is that while they're going in through, just think about, they're sticking a catheter inside somebody's vessels inside their heart. They can have they can have a dissection of those arteries. So going through and causing harm. So they're going to try to help somebody, but they can cause harm by doing this. So that's why not everybody gets a PCI. That's why you have to risk stratify these patients to determine if they should get a PCI or not. Now we're going to talk about, these are complications that can happen after somebody has an MI. One of them can be a papillary muscle rupture. This can happen 3 to 5 days after an NSTEMI or a STEMI. Usually women more than men. And you can have sudden cardiogenic shock and acute whole systolic murmur. So a whole systolic murmur is a murmur during systolic, when the heart is squeezing, and diastolic, while the heart is resting. They can also have pulmonary edema. Just think the heart is not squeezing well, and what's going to happen is you're going to have blood flow going back into the lungs. The echo will show severe mitral regurgitation with a failed leaflet, because those papillary muscles are holding those leaves on the valve, and you can have posterior medial papillary muscle rupture. It can be RCA or dominant left circumflex. It can happen in the anterior papillary muscle. There's a dual blood supply, but if there's a heart attack is big enough, it can take out both the blood supply. And have a left anterior descending artery or left circumflex artery. So what's the importance of this? Is basically someone is going in and they've had a cardiac cath, and in 3 to 5 days after they've had their heart attack, their STEMI, their NSTEMI, then all of a sudden they have sudden cardiogenic shock, and they have a murmur because that valve isn't able to close. Those papillary muscles help close those valves. And you have full opening, so you have whole systolic. I want you to think about that. It's during systolic and diastolic. So you have blood flowing in and out in both cycles. And it results in severe mitral regurgitation. And what that happens from that is, just think if your valve isn't closing, so you're squeezing and the blood's going both ways, you can have pulmonary edema and cardiogenic shock because that valve isn't closing. They'll have a new murmur, and it can lead to, if there's happens to, is they have rapid equalization of the left atrial and ventricle pressures because that valve isn't closing to keep those pressures separate. Findings also can be tachycardia, cool extremities because you're not perfusing. Remember we talked about how important perfusion is, and evidence of end organ hyperperfusion.